Hello all and welcome to your YouTube channel, Dr. Jasmine. I am super excited that all of you requested that we start a series where we talk to you about really important topics and break it down to something which is very simple. I'm extremely thankful to Dr. James, who has been kind and gracious to help us with the series. So Dr. James and I welcome you to our new series, the Tooth Tutors. We will have a lot of amazing, experienced tutors who will help you with topics. Please feel free and put in our comment section if there are any more topics that interest you and if there is anything more that you would like to learn. So today's episode is episode 1, Anatomy of the Head and Neck, and we will talk about cranial nerves. Yes, all my dear friends, dentists and students, this is a topic which a lot of you have sent me an email and messages saying, can we please talk about cranial nerves? And Dr. Jim has been very graceful to walk us through this topic. So welcome to your YouTube channel, Dr. Jasmine.
Hello everyone. I am so happy to welcome all of you to our new short review clips pertaining to the INBDE. My name is Dr. Jim Lozier and I am the author and creator of the original Dental Decks, which helps so many dental students from not only the United States but from around the world prepare for their national boards Part 1 and Part 2. Over the last 8 years, myself and my team have been very busy developing a new study aid called Digital Dental Notes to help prepare students for the new integrated board exam. This great new study program contains over 2,000 standalone questions and 135 cases with over 850 case-based questions. In addition, there's a new awesome e-library which contains over 1,750 pages of concise review on all the subject areas tested on the INBDE. My Digital Dental Notes team and I are excited to be your hosts for a new series of short review clips on INBDE topics. My hope is that these short review clips will enhance your learning experience. But please remember that these short review clips are not meant to be detailed discussions on the topics. If you do desire more detailed explanations and access to all of the review material and cases, I recommend purchasing the entire Digital Dental Notes study program. We are offering a special 15% discount off all our membership plans to all students who are watching. Please email me personally at jlozier, L-O-Z as in zebra, I-E-R, at digitaldentalnotes.com for this special offer. So, what do you say? Let's get started together on your journey to preparing for your INBDE.
So a legal disclaimer, this video is for informational purposes only and does not constitute official advice or endorsement from any institution. Dr. Jim and I have worked really hard to create these series because all of you have been asking a lot of questions about how to study for INBD, where can we get material. So Dr. Jim has been very kind and gracious to help us with this series, and he is conducting the series. Again, all original content, including visual, text, and narration, is copyrighted by Dr. Jasmine and may not be reproduced or distributed without permission. If you think that there is a copyright concern, please send us an email and we will address your issue.
Cranial nerves. The brainstem, which is composed of the midbrain, pons, and medulla oblongata, houses the nuclei that give rise to 10 of the 12 pairs of cranial nerves. The olfactory nerve, cranial nerve 1, and optic nerve, cranial nerve 2, do not originate from a cranial nerve nucleus, but rather they arise from the cerebrum. The olfactory nerve originates from the olfactory bulb, which is a structure located in the forebrain and controls smell. The optic nerve, cranial nerve 2, originates from the retina and transmits visual impulses from the retina to the visual cortex. Important points concerning the cranial nerves. Each cranial nerve nuclei can be described as being either motor or sensory or both. They can also be somatic or visceral. Remember Somatic relates to the body wall, skeletal muscles, and skin. Visceral relates to internal organs and glands. This slide shows you a mnemonic on how to remember whether a cranial nerve has sensory function, motor function, or both. Its mnemonic is "Some say marry money, but my brother says big brains matter more." Also, there is a mnemonic to help you remember the actual 12 cranial nerves. It is O, 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 to touch and feel very green vegetables. Ah, heaven. This slide just clarifies the mnemonic "Some say marry money, but my brother says big brains matter more," and shows you the cranial nerves and whether they are sensory, motor, or both. This slide just reviews the mnemonic O, 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 to touch and feel very green vegetables. Ah, heaven, and how that corresponds to the 12 cranial nerves. Cranial nerve 1, the olfactory nerve. The olfactory nerve is the shortest sensory nerve. The olfactory nerve originates from the olfactory bulb. The olfactory nerve has only a special sensory component which functions in the special sense of smell. The olfactory nerve exits the skull through the cribriform plate of the ethmoid bone. Cranial nerve 2, the optic nerve. The optic nerve originates from the retina. The optic nerve has only a special sensory component as well, which conveys visual information from the retina. The optic nerve leaves the orbital cavity through the optic foramen of the sphenoid bone with the ophthalmic artery. It is important to remember that there are no light-sensitive rods or cones within the optic disc, and this forms a so-called blind spot on the retina. Cranial nerve 3, the oculomotor nerve. The oculomotor nerve originates in the midbrain and runs along the lateral wall of the cavernous sinus, along with cranial nerves 4, 5, and 6, and enters the orbit via the superior orbital fissure. The oculomotor nerve consists of two components, each with distinct function. One component is somatic motor. This provides motor innervation to several extraocular eye muscles. The other component is visceral motor, which has two primary functions: to innervate the ciliary muscles and to constrict the pupils. It is important to remember that the ciliary ganglion is one of the 4 parasympathetic ganglia of the head and neck. This ganglion receives parasympathetic fibers from the oculomotor nerve. Cranial nerve 4, the trochlear nerve. The trochlear nerve originates in the midbrain and runs along the lateral wall of the cavernous sinus along with cranial nerves 3, 5, and 6. From the cavernous sinus, the trochlear nerve enters the orbit via the superior orbital fissure. The trochlear nerve has only a somatic motor component and innervates the superior oblique muscle. There are some unique features of the trochlear nerve. These include the following. It is the only cranial nerve to exit from the dorsal or back surface of the brain. It travels the longest intracranial course. And it also is the smallest nerve in terms of number of axons. It is important to remember a lesion of the trochlear nerve results in double vision due to weakness of the downward and inward eye movement. Cranial nerve 5, the trigeminal nerve. The trigeminal nerve is the largest cranial nerve. It is also the most important nerve to know for dentistry. The cranial nerve originates from 3 sensory nuclei and 1 motor nucleus. The trigeminal nerve exits at the midpons of the brainstem, where its sensory fibers form the trigeminal ganglion. The trigeminal ganglion then divides into 3 main branches known as divisions. These branches are the ophthalmic nerve, the maxillary nerve, and the mandibular nerve. It is very important to note that fibers from the motor root are only distributed to the mandibular nerve. The ophthalmic nerve. The ophthalmic nerve is purely sensory. This nerve provides sensory innervation to the upper face, the forehead, the scalp, and parts of the eye. It also transmits sensory information to the brain. The ophthalmic nerve travels in the wall of the cavernous sinus along with cranial nerves 3, 4, and 6. Just before the ophthalmic nerve exits the skull through the superior orbital fissure, it gives rise to 3 terminal branches. These are the frontal nerve, lacrimal nerve, and nasociliary nerve. The maxillary nerve is also purely sensory. The maxillary nerve provides sensory information to the maxillary teeth and their supporting structures, the hard and soft palate, the maxillary sinus, much of the nasal cavity, and the skin overlying the middle part of the face. Clinically, it is important to remember that this nerve is most frequently affected by trigeminal neuralgia. The maxillary nerve travels in the wall of the cavernous sinus with the trochlear nerve and exits the cranial cavity at the foramen rotundum. The maxillary nerve leaves the skull through the foramen rotundum and crosses the pterygopalatine fossa to enter the orbit through the inferior orbital fissure. It then emerges on the face through the infraorbital foramen, and this is where most of the branches are derived. Branches of the maxillary nerve can be categorized into groups by the location of their origins. There are 4 groups. These are those originating in the cranial cavity, those originating in the pterygopalatine fossa, those originating in the infraorbital canal, and those originating on the face. The mandibular nerve. The mandibular nerve is the largest division of the trigeminal nerve. The mandibular nerve is a mixed nerve made up of a large sensory root and a small motor root. The mandibular nerve carries sensory information from the mucous membranes and floor of the mouth, the lower lip, the mandibular teeth and gingiva, the chin and mandible, parts of the external ear, as well as parts of the meninges. It is important to remember the mandibular nerve supplies general sensation to the anterior 2/3 of the tongue. The special taste sensation is supplied by the chorda tympani, which is a branch of the facial nerve. The mandibular nerve provides motor innervation to the muscles of mastication, the mylohyoid muscle, the tensor tympani muscle, the tensor veli palatini muscle, and the anterior belly of the digastric muscle. The 2 roots of the mandibular nerve emerge from the skull separately through the foramen ovale. Here they unite just outside the skull in the infratemporal fossa and form the main trunk of the mandibular division. The mandibular nerve gives rise to 4 terminal branches in the infratemporal fossa. These are the buccal nerve, inferior alveolar nerve, auriculotemporal nerve, and lingual nerve. Cranial nerve 6, the abducens nerve. The abducens nerve originates in the pons and runs along the lateral wall of the cavernous sinus, along with cranial nerves 3, 4, and 5, and travels in close proximity to the internal carotid artery. From the cavernous sinus, it enters the orbit via the superior orbital fissure. The abducens nerve has only a somatic motor component. It innervates the lateral rectus of the eye, which lets your eye rotate away from the center of your body and look to the left or right. A lesion of the abducens nerve can cause the eye to droop inward and appear cross-eyed, and also cause diplopia or double vision. Cranial nerve 7, the facial nerve. The facial nerve originates in the brainstem between the pons and the medulla. The facial nerve is a nerve of facial expression and is a mixed nerve. The facial nerve travels through the petrous temporal bone in the facial canal. The termination of the facial canal is the stylomastoid foramen, which transmits the facial nerve and the stylomastoid artery. The facial nerve then enters the parotid gland, where it divides into 5 branches that diverge across the facial region. 3 brainstem nuclei contribute to the facial nerve. There is 1 motor nucleus, 1 parasympathetic or secretomotor nucleus, and 1 sensory nucleus. The facial nerve has 4 components with distinct functions. General somatic motor to supply the facial muscles, general visceral motor, which is parasympathetic secretomotor supply to the submandibular and sublingual glands, as well as the lacrimal gland. Special visceral sensory supplies taste sensation from the anterior 2/3 of the tongue. General somatic sensory provides general sensation from the external auditory canal and auricle. It is important to remember that the geniculate ganglion is the sensory ganglion of the facial nerve, supplying taste fibers from the anterior 2/3 of the tongue via chorda tympani, as well as taste fibers from the palate via the greater petrosal nerve. The path of the facial nerve can be divided into 6 segments: the intracranial segment, the meatal segment, the labyrinth segment, the tympanic segment, the mastoid segment, and the extratemporal segment. Important points to remember about the facial nerve. The facial nerve has a complex and broad range of function. Its primary function is as a motor nerve to the muscles of facial expression. However, it also carries taste and parasympathetic fibers that relay in a complex manner with adjacent nerves and ganglia. It is important to note that while the facial nerve branches within the parotid gland, it does not provide autonomic innervation to the gland. This is supplied by the auriculotemporal nerve, a branch of the mandibular nerve. A lesion of the facial nerve usually results in facial weakness. This can be caused by any one of the following: Bell's palsy, polio, otitis media, skull fracture, parotid tumors, Ramsay-Hunt syndrome, which is a complication of the varicella zoster virus infection, and Lyme disease. Cranial nerve 8, the vestibulocochlear nerve. The vestibulocochlear nerve is a sensory nerve that conducts 2 special senses, hearing and balance. It originates in the brainstem between the pons and the medulla and exits the skull via the internal acoustic meatus of the temporal bone. In the internal acoustic meatus, it separates into 2 nerves, the cochlear nerve for hearing and the vestibular nerve for balance. Problems with the vestibulocochlear nerve can result in vertigo, vomiting, ringing in the ears, motion sickness, or even hearing loss. Cranial nerve 9, the glossopharyngeal nerve. The glossopharyngeal nerve originates from the medulla oblongata. The glossopharyngeal nerve contains both motor and sensory fibers and is distributed to the tongue and pharynx. The glossopharyngeal nerve consists of 5 components with distinct functions: general somatic motor, which supplies the stylopharyngeus muscle; general visceral motor, which supplies parasympathetic innervation to the smooth muscle and glands of the pharynx, larynx, and viscera of the thorax and abdomen; visceral sensory, which carries visceral sensory information from the carotid sinus and body; general sensory provides general sensory information from the skin of the external ear, internal surface of the tympanic membrane, upper pharynx, and the posterior 1/3 of the tongue. Special sensory provides taste sensation from the posterior 1/3 of the tongue. The glossopharyngeal nerve exits the medulla oblongata and leaves the skull through the jugular foramen. A lesion of the glossopharyngeal nerve may result in any of the following: the loss of taste and general sensations over the posterior 1/3 of the tongue, trouble in swallowing, and decreased salivation from the parotid gland, and the unilateral reduction of the gag reflex. Cranial nerve 10, the vagus nerve. The vagus nerve is the longest cranial nerve, and since it passes through the neck and thorax to the abdomen, it has the widest distribution in the body. The vagus nerve is a mixed nerve and provides the bulk of the parasympathetic input to the GI system and to the heart. The vagus nerve originates in the medulla and exits the skull through the jugular foramen to enter the carotid space. It descends vertically through the neck within the carotid sheath, traveling between the internal carotid artery and the internal jugular vein down to the neck, chest, and abdomen, reaching all the way to the splenic flexure of the large intestine. There are 4 vagal nuclei within the medulla of the brainstem: the dorsal motor nucleus, the nucleus ambiguus, the solitary nucleus, and the spinal trigeminal nucleus. There are 2 sensory ganglia of the vagus nerve. These are the superior ganglion and the inferior ganglion. The vagus nerve consists of 5 components with distinct functions. Somatic motor supplies the voluntary muscles of the pharynx and most of the larynx, as well as the palatoglossus muscle. Visceral motor supplies parasympathetic innervation to the smooth muscle and glands of the pharynx, larynx, and the viscera of the thorax and abdomen. Visceral sensory provides visceral sensory information from the larynx, esophagus, trachea, and abdominal and thoracic viscera, as well as the stretch receptors of the aortic arch and chemoreceptors of the aortic bodies. General sensory provides general sensory information from the skin of the back of the ear and external auditory meatus, parts of the external surface of the tympanic membrane, and the pharynx. Special sensory is a very minor component of the vagus nerve and provides taste sensation from the epiglottic region. It is important to remember that at the base of the neck, the vagus nerve enters the thorax, and the right and left vagus nerves take different pathways. The right vagus nerve passes in front of the right subclavian artery and behind the sternoclavicular joint to enter the thorax. The left vagus nerve passes inferiorly between the left common carotid and left subclavian arteries behind the sternoclavicular joint to enter the thorax. Both left and right vagus nerves subsequently enter the abdomen through the esophageal hiatus of the diaphragm and follow their own individual path to their terminal branches. Branches of the vagus nerve are grouped according to where they form. Branches in the jugular fossa, branches in the neck, branches in the thorax, and branches in the abdomen. The symptoms of a lesion along the vagus nerve are dependent on where the lesion is located and may include difficulty in swallowing and in speaking, poor digestion, decreased peristalsis, and asymmetrical elevation of the palate and hoarseness. Cranial nerve 11, the accessory nerve. The accessory nerve has a cranial root and a spinal root, both of which consist of somatic motor fibers. The cranial root carries motor innervation to the muscles of the larynx and pharynx, as well as muscles of the soft palate, except tensor veli palatini, which is innervated by the mandibular branch of the trigeminal nerve. The spinal root innervates the trapezius and sternocleidomastoid muscles. The most common cause of accessory nerve damage is iatrogenic. Clinical features of damage of the accessory nerve are muscle wasting and partial paralysis of the sternocleidomastoid, resulting in the inability to rotate the head or weakness in shrugging the shoulders. Cranial nerve 12, the hypoglossal nerve. The hypoglossal nerve arises from the hypoglossal nucleus in the medulla and exits the skull via the hypoglossal canal of the occipital bone. After exiting the hypoglossal canal, the hypoglossal nerve receives fibers from C1 and C2 of the cervical plexus, which go on further in the neck to supply the infrahyoid muscles. The hypoglossal nerve then passes laterally and downward to lie between the internal carotid artery and internal jugular vein. It then loops anteriorly to run along the lateral surface of the hyoglossus muscle deep to the mylohyoid muscle to enter the tongue. It is important to remember the hypoglossal nerve has only a somatic motor component. It is responsible for motor innervation of most of the muscles of the tongue, except for the palatoglossus. The C1 and C2 fibers that travel with the hypoglossus nerve also have a motor function. They branch off to innervate the geniohyoid and thyrohyoid muscles. Another branch containing C1, C2 fibers descends to supply the ansa cervicalis, which is a loop of nerves that is part of the cervical plexus. From the ansa cervicalis, the nerves arise to innervate the omohyoid, sternohyoid, and sternothyroid muscles. It is also important to identify clinically lesions of the hypoglossal nerve. Patients will present with deviation of the tongue towards the damaged side on protrusion due to lack of function of the genioglossus muscle. There can also be paralysis, atrophy, and fasciculations of the tongue on the ipsilateral side, meaning the same side as the lesion. Clinical correlations and significance slide. Trigeminal neuralgia is a condition that causes intense pain similar to an electric shock on one side of the face. The maxillary branch of the trigeminal nerve is most frequently affected by trigeminal neuralgia. Even light touch from brushing the teeth or washing the face may trigger a jolt of pain. Trigeminal neuralgia can be long-lasting, and it is more common in women and people older than 50. Carbamazepine, sold under the trade name Tegretol, has been shown to be effective in treating trigeminal neuralgia. Bell's palsy is a condition that causes temporary facial paralysis. It usually only affects the muscles on one side of the face. It is caused by inflammation and compression of the facial nerve. As a dentist, it is important to remember that Bell's palsy may happen when the local anesthetic solution is injected too far posteriorly when giving an inferior alveolar nerve block and the solution is delivered into the parotid substance. The parotid gland often incorporates facial nerves, and this could lead to transient facial paralysis. These patients usually recover a few hours later. The jaw jerk reflex is a stretch reflex used to test the status of a patient's trigeminal nerve function. The jaw jerk reflex involves the contraction of the masseter and temporalis muscles when the patient's lower jaw is tapped. The gag reflex is mediated by the glossopharyngeal nerve and the vagus nerve. Patients with a hypersensitive gag reflex may state that they have issues swallowing pills or larger pieces of food. Typically, these patients may also delay going to the dentist or practicing appropriate oral hygiene due to the presence of a hyperactive gag reflex. Sensory supply to the tongue involves several different nerves. Taste sensation to the anterior 2/3 of the tongue is carried by special sensory nerve fibers of the chorda tympani, which is a branch of the facial nerve. Remember, this nerve also carries secretomotor fibers to the submandibular and sublingual glands. General sensation to the anterior 2/3 of the tongue is supplied by the lingual nerve, which is a branch of the mandibular division of the trigeminal nerve. Taste and sensation to the posterior 1/3 is supplied by the glossopharyngeal nerve in addition to a small branch of the internal laryngeal nerve, which is a branch of the vagus nerve. Key points concerning the tongue. The tongue is a muscular organ of the oral cavity that has an important role in taste, swallowing, and speech. There are 4 paired intrinsic muscles and 4 paired extrinsic muscles of the tongue. The motor innervation to the intrinsic muscles of the tongue is via the hypoglossal nerve. The extrinsic muscles of the tongue also are innervated by the hypoglossal nerve, with the exception of the palatoglossus muscle, which is innervated by the vagus nerve. The muscles, neurovasculature, and lymphatics of the tongue serve an important role in determining the spread of malignancy and surgical approach to head and neck pathology. Damage to the hypoglossal nerve leads to deviation towards the side of the lesion. That concludes the review of the cranial nerves. Guess what time it is? You got it. It's quiz time. The following slides will have questions. I will pause for 10 to 15 seconds for you to think of the answer, and then I will tell you what the correct answer is. The glossopharyngeal nerve exits the medulla oblongata and passes laterally in the posterior cranial fossa and leaves the skull through the foramen ovale, superior orbital fissure, jugular foramen, or hypoglossal canal? The correct answer is jugular foramen. Which nerve provides taste to the anterior 2/3 of the tongue? Taste sensation to the anterior 2/3 of the tongue is carried by special sensory nerve fibers of the chorda tympani, a branch of the facial nerve. Remember, this nerve also carries secretomotor fibers to the submandibular and sublingual glands. The trigeminal nerve has how many brainstem nuclei? 1 sensory and 3 motor nuclei, 2 sensory and 2 motor nuclei, 3 sensory and 1 motor nuclei, or 4 motor nuclei. The correct answer is 3 sensory and 1 motor nuclei. Which cranial nerve supplies sensory innervation to the parotid gland? Sensory innervation to the parotid gland is supplied by the auriculotemporal nerve, which is a branch of the mandibular division of the trigeminal nerve. Remember, the parotid gland receives sensory and autonomic innervation. The autonomic innervation controls the rate of saliva production. The parasympathetic innervation to the parotid gland has a complex path. It begins with the glossopharyngeal nerve. This nerve synapses with the otic ganglion. The auriculotemporal nerve then carries parasympathetic fibers from the otic ganglion to the parotid gland. Parasympathetic stimulation causes an increase in saliva production. Which of the following cranial nerves travels the longest intracranial course? The oculomotor nerve, the trochlear nerve, the trigeminal nerve, or the facial nerve? The correct answer is trochlear nerve. A 43-year-old patient presents with sudden onset of unilateral facial paralysis. He cannot close his left eye and has drooping at the left corner of his mouth. Taste sensation is also reduced on the anterior 2/3 of the tongue. Which cranial nerve is most likely affected? The trigeminal nerve, the facial nerve, the glossopharyngeal nerve, or the vagus nerve? The correct answer is facial nerve. Which division of the trigeminal nerve is most frequently affected by trigeminal neuralgia? The ophthalmic nerve, the maxillary nerve, or the mandibular nerve? The correct answer is maxillary nerve. Which of the following is the largest branch of the mandibular nerve? The auriculotemporal nerve, the lingual nerve, the inferior alveolar nerve, or buccal nerve? The correct answer is inferior alveolar nerve. During an intraoral exam, a patient demonstrates no gag reflex. Stimulation of the posterior pharyngeal wall does not elicit a response. Which pair of cranial nerves is most likely involved? The glossopharyngeal and vagus nerves, the trigeminal and facial nerves, the hypoglossal and vagus nerves, the trigeminal and glossopharyngeal nerves? The correct answer is the glossopharyngeal and vagus nerves. A patient undergoing third molar extraction complains of numbness in the lower lip and chin on the right side postoperatively. Which nerve was likely traumatized during the procedure? The lingual nerve, the buccal nerve, the inferior alveolar nerve, or the facial nerve? The correct answer is inferior alveolar nerve. A patient reports double vision when walking downstairs. Examination shows the inability to depress the eye when adducted. Which cranial nerve is involved? The oculomotor nerve, the trochlear nerve, the abducens nerve, or the facial nerve? The correct answer is the trochlear nerve. Please match the cranial nerve with its function. The optic nerve, cranial nerve 2, the function is vision. The vagus nerve, cranial nerve 10, the function is parasympathetic innervation to the thorax and abdomen. The abducens nerve, cranial nerve 6, is responsible for eye movement. And the vestibulocochlear nerve, cranial nerve 8, is responsible for hearing and balance. The cranial nerve responsible for innervating the muscles of mastication is the correct answer is the mandibular branch of the trigeminal nerve. Remember, the muscles of mastication are a group of muscles that consist of the temporalis, the masseter, the medial pterygoid, and the lateral pterygoid muscles. Here are a few key takeaways to the cranial nerves. Remember, there are 12 cranial nerves. They play key roles in sensory, motor, and autonomic functions in the body. The trigeminal nerve, the facial nerve, the glossopharyngeal nerve, and the hypoglossal nerve are the most relevant to dentistry. However, don't forget that vagus nerve, as it is also tested heavily on the INBDE. For the cranial nerves, you need to know their paths, functions, and clinical signs of pathology. I hope everyone enjoyed this short review clip on the cranial nerves. It has been my pleasure hosting this review. Please leave your comments and questions below, and myself and my team will respond accordingly. Remember, if you desire a more detailed review for the INBDE and access to the entire digital dental note study program, which includes the amazing e-library with over 1,750 pages of concise review of INBDE topics and over 2,000 standalone questions with 135 cases and over 850 case-based study questions, please visit us at www.digitaldentalnotes.com. And don't forget the 15% off on our subscription plans just for watching this review clip. Stay tuned for our next review clip of INBDE topics coming soon. Take care.
Thank you.
Thank you all for patiently listening to this video. I hope Dr. Jim answered a lot of questions that you had about cranial nerves. The person you heard on the last slide is my little son, who I think has learned cranial nerves by now. He's about 2 years old. But thank you all. Stay tuned. In the comment section, please let me know what other video topics interest you. Please like, share, and subscribe. Study hard, study smart, and wish you all the best with your application and INBDE exams.